Thanks, Lisa, and welcome everybody. It's a pleasure to talk to you all tonight. I know that we've been having a lot of webinars, and there's a lot of information and a lot of literature coming out on ankle replacement. But what's happening is the more ankle replacements that are occurring, the more revisions that are showing up at our doors. And so my goal tonight will be to discuss some of these revisions and give you some ideas that I've employed for revisions, and probably you have too. But there may be some unique situations, and this may help you in some of your patients, because this is going to be a much bigger field as we move on. These are my disclosures. Now, what is the definition of a revision? Well, it ought to be the changing out of one or more components, or any additional surgery, or conversion to an arthrodesis. Sometimes in the articles, particularly when they're written by the designer of the prosthesis, they only include that first definition, that is changing out of one or more components. But any additional surgery is probably better considered a revision. I know in Bonnen's article in 2011 on the Salto ankle, he had a 35% return to surgery rate over a 9-year period. So that means that if you're doing patients who are going to live approximately 9 or more years after the surgery, there's a 1 in 3 chance that those people are going to come back to surgery. Now, I like this article. This was written in 2011. It talks about revision rates after total ankle arthroplasty in sample-based clinical studies and national registries. And what they found that the average revision rate, that is any surgery, was over 20% after 5 years, and all the way up to 43.5% after 10 years. You can only imagine that at 12 years after surgery, you're going to be revising at least half of your patients. And the other interesting thing was, and I don't think that the designers of ankles are purposely misleading us, but it's a natural bias for them to look at their prosthesis and maybe not have the same kind of critical eye that we would be looking at them. And so they found the average revision rate published in peer-reviewed scientific articles was significantly lower than the outcome achieved in national arthroplasty registry data. So what that means is that there's some exaggeration in the articles that don't fully enlighten us as to the number of revisions any particular prosthesis is having. Now, let's take a look at some examples. We certainly have had a long experience with the agility ankles, and we know that there are some problems with it, and that they have a tendency to create osteolysis and have aseptic loosening. There is another article out by Sajogin in 2013 in the Journal of Arthroplasty, and he looked at the failure rate of total hips, total knees, and total ankles. And he cited that aseptic loosening was a complication in 38% of the studies that he reviewed. And the next big one, and something we can do something about, is there was a 15% failure rate for technical errors. And those are the errors that those of us who have been total ankles have made. And so we're trying to learn more, and that's the benefit of these webinars, to try and increase our technical experience so there are less failures. But let's go back to the agility to INBONE. This is a 76-year-old male with an agility ankle implanted 9 years ago, and he's done well. And then beginning 2 months ago, he started having discomfort. No history of trauma, no negative vascular studies. And so this is his x-ray. And you can see that he's got a good syndesmotic fusion, 2 screws across that area. But if you look, and I'm going to use my cursor here, if you look, you can see this large cyst on the medial side, okay? and then there's another cyst down here in the medial side of the talus. The orientation of the prosthesis on the AP view doesn't look too bad. On this mortise view and lateral view, you can see that there's probably incomplete fixation of the tibial component in the tibia. You see these cystic areas coming up in the posterior and again in the anterior side, and again in what has been particularly prevalent in the agility ankle is you see that lucency coming underneath the anterior aspect of the talar component and in the posterior aspect. The subtalar joint still doesn't look too bad, the tailnavicular joint doesn't look too bad, and the calcaneus doesn't look too bad. Well, when we get a CT scan, you know that we can see a lot more. So now we can see the expansive cyst over in the medial side of the tibia, and then there's a large cyst here in the talus. The calcaneus, again, looks fairly good. These are probably just degenerative cysts and not associated with any polyethylene debris. Again, on the AP view, we see the large cyst in the tibia, all right, extending down to the prosthesis, and then we see on the lateral side another talar cyst there, and then we see a lot of erosion, which is common with the agility, along the fibular side. And so the question is, can we revise this, and he's uncomfortable, so it's not going to be something that we can just watch, or is there something else we can do? Again, on the cross section, you can see that large cyst on the medial side, and you can see those cysts on in the talus on the CT scan. Well, he didn't want to get a fusion, and so we wanted to oblige him. And so the first thing I do when I'm revising the agility ankle is to put prophylactic screws in, particularly along the medium malleolus here, because you know this is just ready to break. And on the lateral side, I won't hesitate to put screws in there, but it looked like the fibula was reasonably intact. Now, the nice thing about using the INBONE for these patients is that we have a nice flat cut on the top of the talus. So as long as we have a rim of talus left, we can mount that flat prosthesis onto that area and get a pretty good stable construct. This is the new Agility 2. And you'll see that it has the anterior prongs here in addition to the central stem. And this gives reasonably good fixation to that area in spite of those talar cysts, which have been bone grafted with allograft in this particular case. And here, even though it's used relatively off-label, I've added some segments, a segment, to the standard tibial stem. That is, instead of the standard 4, I've got 1, 2, 3, 4, 5. And I've done that because of the weakness over here on the medial side. And this is all bone grafted with allograft. And the construct's not looking too bad. So in spite of the large cyst in the medium malleolar region and the talus, we're able to come in and put a prosthesis in that has some possibility of capturing bone. Here's the patient 6 months out. You can see that the allograft has nicely incorporated into the large cystic area along the medium malleolus, and the screws have added support for that, and the patient has been doing reasonably well. And you can see the calcaneal view and the lateral view, which look like this prosthesis may make it for the rest of this gentleman's life. Now, we wrote up these patients in an article with DeVries, Scott, Burlett, Heyer, and Tom Lee and myself, and we looked at 14 patients who were converted from agility total ankle replacement to an INBONE total ankle replacement, and I'll refer you to that article for the details. I will say that the difficulty of this procedure is demonstrated by a relatively high complication rate and 2 early failures. So these are big-time surgeries in a small joint, and have to be approached with some caution. Now, I'm going to show you a patient that I did, and I've got a phrase for this kind of finding, and I call it the horizontal median malleolus. And this is a median malleolus which has been deformed through trauma or gradual wear such that it assumes a posture more horizontal than normal. And it suggests a correction to make a more vertical median malleolus. And so here's the patient, a 60-year-old family physician with a history of multiple sprains in his left ankle. He's got a significant varus deformity on that left side. It's a 25-degree deformity, so that's certainly getting up there, probably with lateral ligament instability as well. But you see how the median malleolus is in a horizontal position. In the mortise view and the lateral view. Now, with the INBONE at the time of surgery for these big-time deformities, you can either do the ligament reconstruction right at the beginning, and then you're able to balance the tibia and the talus simultaneously and make the cuts, or you can do what I've done here, and that is to put the guide and the drill into the calcaneus and the talus, and then rotate the foot around before I drill up into the tibia. And again, here I've learned to do the lateral reconstruction first when the tibia on that far left tibial talar space opens up so widely. On the lateral view, it's not such a big deal. It's much easier. But again, you get the sense that that tibial talar joint space is just too wide. And I should have done the ligament reconstruction first, and I would have been able to swing this back into position. Then the stem went into too much varus, and to get it out of there, I tried a screw to push it over. But I've since learned that trimming away a little bit of the plafond with the small reciprocating saw and then impacting the prosthesis will allow the stem to straighten out. All right, here's the lateral. Again, not too bad. This is the INBONE 1. And at 6 weeks, I wasn't displeased with the prosthesis, and the patient was doing very well. Well, he came back, and again, another 6-week shot and a little bit of varus, but not bad. He came back 13 months after surgery, and to get him out of that varus position, I had done a deltoid release and brought him all the way back. But let me go back here and show you how much space there is between the median malleolus and the prosthesis. Well, that's because of this horizontal median malleolus, where it just sticks out to the side like that. And even though I had balanced him at surgery, and in 6 weeks he looked good, he went back to this varus position after the surgery. Well, I learned that I could still salvage this with bringing that median malleolus down. So the patient came back now with the anterior wound healed, and you can consider this a staged procedure if you want, but I took the median malleolus, did a transverse osteotomy, filled in the defect with iliac crest bone, and then pinned it in position, put a plate on that area, went on to reconstruct the lateral ligament, and I was able to get a good balance there. See how that median malleolus has been turned from a horizontal median malleolus back to a more vertical median malleolus to support the talus. And I'm doing this more and more now, bringing the medial and lateral talus down in the case of a valgus deformity down to support that. Lisa, I'm going to stop there and see if there are any questions in that chat box.
There are not at this time.
Okay. Let's keep going here. And you can see I typically use suture tacks, and for the ligament reconstruction, I will do a Brostrom ligament reconstruction. In fact, I did one today. So it's not uncommon to have to do these, even as today's case was with a valgus ankle, and that was in a saltolaris ankle. Now, impingement. I don't know about you, but this has been a real bugger for me. It's one of the most common problems in total ankle arthroplasty. I think people don't report it nearly as much as it occurs, but when your patient comes in and everything looks good, but they complain of pain on the medial or lateral side, then that's impingement. And we've learned not to oversize the talus, but nonetheless, particularly in a mobile-bearing prosthesis, if you get any varus or valgus tilt of that tibial component, that talar component can slide into the malleolus, and that can be a problem. So much so that patients are willing to undergo surgery again to relieve that pain. Now, this can be relieved open or arthroscopically. Let me show you a patient. This is a very, excuse me, very narrow, thin patient with a very small intermalleolar distance. She had this prior screw from trauma, and now she's got arthritis in her ankle. Well, her ankle is done, and she has a slight varus position of her tibial plate, probably about 3 degrees. But you can see very readily that the talar component looks like it's impinging on the medial malleolus. Well, I see other x-rays like this, and the patients have no pain. And yet the next person walks in and has exactly the same x-ray and significant pain. But here I think it's clear that she has impingement, and this was an extra small talar component. Sometimes you just got to keep trimming away the bone and putting a prophylactic screw in. But nonetheless, we have this situation, and we want to try to help her. I have gone in arthroscopically. Now here you see a shaver going in and removing the soft tissue, and then I'm trying to find the malleolus here, and that's not always easy with the curette. And then there are newer burrs out now that allow me to go in, some of the eggshell-shaped burrs. If I can give you one clue to doing this, it's to use the Arthrocare wand to take away the capsule. Here I am on the medial side. You can see the cancellous bone on the medial malleolar region. This does take a little bit of time. I don't think I can do it in less than an hour both sides. And then I'm going all the way in, and then on the medial side, I'm going all the way down until I see the posterior tibial tendon and know that I'm clear. On the lateral side, I go until I come to the perineal tendons. And so here she is with that bone debrided on the medial malleolus, and I think you can see that. So we wrote these up. We did debrided 20 ankles and 20 patients with symptomatic bony impingement following total ankle arthroplasties, and had good results with that. And I'm continuing to do that for patients, although I'm using the Arthrocare wand now to obliterate the capsular tissue and scar tissue that's sitting on the medial malleolus, so I can get to that as quickly as possible. And then I'm using a unhooded burr to go in there and reestablish the gutter. And so now you can imagine I'm trying to avoid this problem by doing a much better job of cleaning out the gutters at the time of the original surgery. There is a 4mm long, skinny 7-inch rongeur, and it has a 4mm wide bite. And I found that by taking that down into the gutters, and even though the talus will push over to the medial or lateral opposite side when I push it down, if I can get that down to both sides, and even though the talus moves back and forth, then if I had 4mm and pushed the talus up against the malleolus, then I would have a 2mm opening on both sides. And so I'm doing that, and I'm trimming away bone with the reciprocating saw, and I'm having a lot less problem with impingement.
Dr. Diorio, I do have a couple of questions that have come in.
Okay, great.
I have one. What's the post-op protocol, such as CAST, ROM, WB?
For the removal of the bony impingement, I put them in a cast just to protect the arthroscopic wounds. That cast comes off in 2 weeks. I take out the stitches, put them in a removable boot, let them full weight bear, and they can return to activity as soon as they're comfortable.
Okay, thank you. And then I have, oh, I'm sorry, he's responded. I mean the REV for total ankle replacement.
So for the complete revision, I treat them just like a primary, and that's 6 weeks in a cast, non-weight bearing, and then to a removable boot, and weight bearing is tolerated for a couple weeks, and then into shoes.
Okay. My second question from Dr. Pellegrini, how long do you wait before doing an arthroscopic debridement? Do you use steroid injections?
No, I don't use any steroid injections, and I take them to surgery as soon as they've decided that they would want surgery for the relief of impingement. You can do them openly. You can make an incision there. That's probably a little faster, but I think it's a little bit more morbidity than doing it arthroscopically. Okay, let's look at a talar collapse, no history of trauma. I think this has happened to all people that do total ankles and can happen to any particular prosthesis. In this particular patient, she was a 68-year-old female with talar AVN, possibly secondary to smoking, but there wasn't any history of trauma, and you can see the increased sclerosis on her right ankle of the talus. And you can see, and I think this is the giveaway, this diminution in the talar height. And so this is a sign that that talus just isn't healthy. But I knew that, but I thought we could get by. So I did the INBONE one ankle on her some years ago. I did a minimal exposure to her subtalar joint, and then we put fusion bars underneath the prosthesis, understanding that it might collapse. So there's several things wrong with this. One, I don't think these kinds of patients should be done with total ankles. I think they have a high incidence of failure. And two, if you're going to do a subtalar arthrodesis now, and I've changed, I don't think we should ever bring the hardware from the front. I think that adds additional jeopardy to the blood supply to the talus. And so now I'm putting in the screws across the subtalar joint from the posterior tuberosity to the calcaneus and coming up more vertically and trying to avoid the artery of the sinus tarsi and preserve the blood supply to the talus. Well, this is what she looked like after surgery, and so both she and I were pleased. And this doesn't look too bad. This is approximately 6 months out from the surgery, and it looks like it might be holding up. But gradually she comes in, and now we see the talar component is beginning to sink into the talus, and it might be held up by the fusion bars and the screw, but it's not going to be solid. It's not going to get a bony ingrowth. And we revised her to removing the ankle out and putting in a TTC nail from the calcaneus up through the talus, and then filling in that with a bone graft. Now, the nice thing about doing this is she's back to playing golf. She walks without a limp. I'm sure that leg gets more tired than the other leg when she goes out, but it really has restored her function, and I have a low threshold for doing that in these people and offering them that surgery. Now that's done straight posteriorly, and I always leave the fibula. Let's look at this 73-year-old male, right ankle pain for 2 years. Again, he has a valgus deformity, but you can see there's no avascular necrosis there. There's a nice homogeneous integrity to the talus. Now, at the time of his INBONE ankle, I think you can criticize this and say that there was a little bit extra bone taken off the posterior aspect of the talus, and indeed, I certainly try to leave more talus now and try to get that flat cut across that area. But this gentleman returned to a high level of activity, but gradually his x-rays showed that he was collapsing the talar component down into the talus. And then finally you can see it's not like he fractured this and there are fragments of the talus all over. It just absolutely disappears until these people will come down to the calcaneus. So here, no screws were used anteriorly. Maybe some bone was taken off. Maybe he had a situation where he didn't have a normal blood supply to the talus. But I have seen this several times, and other doctors have referred their patients to me with this problem as well. And again, we can salvage these this is a different patient, but we can salvage these patients by going in a prone position, making a posterior exposure here in a patient who doesn't have a total ankle, taking out the total ankle from the posterior approach. Again, I've split the Achilles tendon, and this is to show you that you can get to the ankle and the subtalar joint, clean them both out, and then you can put a femoral head in, as I've done here, and again, put the screws going from posterior to anterior through the calcaneus and the rod, and these will heal. Typically, we will use a lot of bone graft. I won't hesitate to put a little vancomycin in the bone graft for protection. We will use a bone morphogenic protein, and we can get a very solid construct. And so it's a nice save for these people and allows them a very functional extremity afterward. Let's talk a little bit about osteolysis. Again, this is a nemesis, particularly in younger active patients. So here's a 60-year-old male with arthritis in the right ankle from multiple sprains. Again, no big deformity, but you can see that there's a complete loss of cartilage in the tibial-talar joint space. In the lateral view, and again, he gets his in-bone ankle, and he does well. He has no pain. He's very excited. So excited, in fact, that he returns to doing his usual activity of carrying the canoe down to the river and being a whitewater river instructor. High stress to these total ankles, which was not intended. And he comes back at 3 years, and again, now you can see that there's some lytic formation in the bottom of the stem and around the base of the prosthesis. You can also see that there's some lucency beneath the talar component. And so this is unusual for this prosthesis, and I think it's related to how active this guy was and how much stress he took over his shoulders when he carried the canoe down to the river. Now, here's the cyst at the distal part of the stem, and you can see it wraps all the way around the stem. These cystic changes were there before surgery. I did not fuse his subtalar joint because he had good preservation of the posterior facet. And I elected to treat him with a calcium phosphate injection. So I took him to surgery, took off a window over the anterior tibia, filled this area with calcium phosphate in a liquid form so that we go around the prosthesis, and similarly dealt with his talar component. So I don't know that that's the best way to do it. I used it on somebody else who had a star anchor replacement, and there was complete dissolving of the calcium phosphate back into solution, and I ended up having to come back and put cement in. So I reviewed the world's literature on the use of cement and calcium phosphate. The answer is we don't know quite what to do with these cysts. I think certainly if I'm revising an ankle and they're big, then I'm using allograft bone. But in the last case I mentioned to you about the star, it was such a big cyst in the talus, I was worried about imminent collapse, and so I filled it with cement, and we'll see how that does. Now, here was an ankle that was approved for release in the United States called the Eclipse ankle. This is a 67-year-old male. Let me go back here. Sorry. Hit the wrong button where it went to the end. Okay, so this is a 67-year-old male with an ankle fusion on the right. He didn't like it. He decided to get the new Eclipse ankle. This was an ankle designed to go in from the medial or lateral side. And you can see that he's got collapse of the medial malleolar side and screws going through that side. And so that didn't work, and the prosthesis was taken off the market. He came to me. Again, I thought we could revise him with the INBONE ankle. And so I took the prosthesis, put the screws again prophylactically, and for that fixation of the medial malleolus, put some longer stem pieces in, and I was real pleased, and he did real well for about a year. But then he came back, and he fractured the screws in the medial region, which didn't heal. His talar component slid medially, and if you look real carefully, you can see that he's fractured his stem. Well, that's almost unheard of, but it nonetheless happened. You can see we cut down on his talar component a little bit, but all that seemed to survive. So then I came back and had to do a repair of the non-union on the medial side, put in a plate and bone graft. He was diabetic. I let 6 weeks go by, and then I came back and had to repair his broken stem from the INBONE ankle, and you can see that slight offset there in the prosthesis. And so I took that out, bone grafted that area, was able to replace the tibial component without replacing the talar component, and he has now gone to walking 15 miles a week. So it shows that these can be fixed, but not always easy and not without potential complications. Another 68-year-old male fell at home. He had this large plate. One of the things that I've cautioned the fellows with, and by the way, I told them I would do a shout out tonight if they were out there, and that's Dr. Malouf, Dr. Halloran, and Dr. Dromakopoulos, and they are becoming excellent ankle surgeons. But here in this case, we have a large plate. We're worried about a little avascular necrosis in the distal tibia. You can see it just doesn't look right. So I went in and I put the prosthesis in, but lo and behold, he had a large non-union across the distal tibia. But I thought, you know, that would heal, and I bone grafted it, put fixation in. I got a nice cut on the talus. But the question is, well, what do I do now? And he came back in, and this is at about a year, and you'll see that the base plate to the INBONE prosthesis is crooked now, and it was straight. And so it's clear to me that he's fractured the tibial stem, something that's very uncommon. Well, when I went to do the revision and I cleaned up everything, I ended up with a larger space than they had a polyethylene. The largest polyethylene is 14 millimeters. So out of necessity, I crafted a Calcar femoral head horse collar, and I took that horse collar and I put it at the base of the stem, hoping that the stem would get support above that, and yet that would act as a spacer to bring the prosthesis down. And now you can see that I got by with a 12 millimeter prosthesis, and this was done about a year ago, and so far so good, and we're hoping that incorporates gradually and the bone gets solid fixation of the prosthesis. Well, it wouldn't be a good revision talk without at least one infection. We don't get them very often, but certainly 1 to 2% will get infected in spite of our best efforts. So here's a 58-year-old male. He has a moderate deformity. We do his ankle replacement. He does well, but he comes in very shortly thereafter, and he's obviously got an infected ankle. Well, it's easy to take these out, and so you can see we have a little cut mark up there where we took and cut the anterior cortex and lifted the prosthesis out and then put a methyl methacrylate spacer in. We came back at 8 weeks and put the prosthesis in, which was not hard, but you can see that over a 2-year period of time, he's had some migration of the talar component, and I'm only hoping that this holds up and does not completely collapse. Otherwise, we'll have to do an arthrodesis. So handling the infections when they're acute is to take the prosthesis out, put in a spacer, and move on. Now here's a 68-year-old female, status post-tibial fracture, gradually increasing pain for 3 years. You can see she's got a significant deformity, and again, she's got that small medium malleolus with a 22-degree varus deformity. In these kinds of cases, I'm trying to bring down that medium malleolus So I've shifted the prosthesis over to the medial side. There's a slight amount of varus there, and I've just done minimal fixation of the median malleolus. And you can see I had to get by that isthmus in the prosthesis. Well, she collapsed back into about 12 degrees of varus because of the angulation of the fibula and the varus deformity. And so what do you do for patients like this who are symptomatic? Well, we did an osteotomy. It included an osteotomy of the fibula and plating the median malleolus. We got her back to about 5 degrees of varus, not perfect, but it was asymptomatic, and this was 9 months out, and she's doing well with that. So you can correct these by doing an osteotomy above the prosthesis when they've been in. So in conclusion, revisions, we're going to see a lot more of these, will continue to be more common in the ankle than the hip or the knee. The newer prostheses and techniques will alleviate some of these problems, but not all of them. And surgeons will need to continue extreme vigilance in patient selection, avoiding patients with any history of AVN, and techniques to avoid the majority of these revisions.